6:30 now, so we can go ahead and start.
Yeah.
Well, hello everyone. Thank you for joining us for another Mind, Body, and Soul event. I am Aisha Brooks. I'm the Status Neutral Contract Monitor for BDH, and I'm with my colleague, Jason Watler.
Hello, everybody. Welcome to Mind, Body, Soul. My name is Jason Watler. I am I work on the Virginia Department of Health hotline and also coordinate Mind, Body, Soul with Aisha. And welcome back to our installment of our new installment of harm reduction, what it is and what it ain't. So, and we're happy to be partnered again with LGBT Life Center. LGBT Life Center again. So yes, take it away.
And we will get started with Ms. Jamel James of the National HIV Behavioral Surveillance Team. And I will send it over to you, Robin.
Yep. Okay, thank you. So Jamel is the project coordinator for the National HIV Behavioral Surveillance Team. And she will just do a quick PowerPoint on some of the services and the survey that is actually being conducted now. So let me just go ahead and share my screen. Okay, can everybody?
Thank you, Robin.
You're welcome. So can you see the screen?
I can see the screen. It looks like part of the email is on there.
Okay.
As well. Want to make it bigger?
I think that's how big as it goes right now. All right. I think that's as big as it goes.
Okay. Okay. I can go ahead and start. So as Robin stated, my name is Jamel James. I am the project coordinator for the National HIV Behavioral Surveillance Project. And I'm going to do a quick PowerPoint, basically outlining the project and then giving some brief data on the last PWID cycle that we actually did. So if you could go next screen for me, Robin.
Can you see it?
No, I don't see the next screen. I just see the first one.
Okay.
Robin, do you think if you click, I wonder if we click start slideshow, if that would make it bigger and we'd be able to see the next slide.
Yeah.
Okay, let's see here. Because what I see is not what you see. I don't see the small version of it. I see the very large version of this. So let me just stop real quick. Sorry. Is that better?
Yes.
Okay.
There we go. Yep.
All right. Thank you. Minor technical difficulties, but we're going to make it through.
We'll make it work. So next, okay, here we go. So what is NHBS? So NHBS is a CDC funded project that began in 2003. And so Virginia joined as a project site in 2016. So this is a collaboration with CDC and the Virginia Department of Health. The purpose of the project is to learn more about the behaviors of people at a higher risk of HIV infection. And so also Virginia is one of 23 project areas who actually participate in NHBS. And we do the actual Eastern region, which I'll show you guys in a minute. So in Virginia, we actually collect data from residents in the Eastern Health region. All right, so program goals. We want to monitor trends in HIV prevalence among groups at higher risk for HIV infection. We also want to monitor high-risk behaviors, HIV risk behaviors, HIV testing, and use of HIV prevention services. Populations of focus. So NHBS collects data in rotating annual cycles in 3 different populations at increased risk for HIV. So our first population would be our men who have sex with men, the MSM, and the years on here are going in the rotating cycles. You'll see that some of them are not, and that was because of COVID. So the men who have sex with men, people who inject drugs, which was formerly known as our IDU cycle, injection drug use cycle, but it is now PWID, and then our high-risk heterosexually active persons. So if you look at the first one, you'll see 2017, and then it goes to 2020. That would have actually been the rotating cycle. So it will start with MSM, and then PWID, and then HET. However, because COVID came along, the MSM had to be repeated in 21. And so now we're on PWID in 22. But if you look back, we're going to go back to MSM in 23 and then start the cycle over. So that, COVID just had things a little bit tied up, but the cycles will eventually get back in the proper rotation. Now for the breakdown, how does this work exactly? All right, so respondent-driven sampling. So for our PWID and HET cycles, what we do is we locate seeds. We call them seeds. They are our initial participants. These may be people that we have found in the actual PWID community that will help us essentially grow this study. We find our seeds, the seeds complete the survey, and they're issued coupons to recruit their peers. So we want them to find people that are in their actual social circle, because this is how we're gonna to grow the study. So once the peers receive the coupons and complete the survey, the peers will now take the survey and recruit, just like the seeds did. And that is, like I stated, how we increase our survey participation through those actual peer networks. And then the process continues until we reach a benchmark of 500. Now, there are times in the past that they have reached well over 500, but that is fine. But the goal is 500. All right, venue-based sampling. This is for our MSM cycle only. Our MSM cycle is a little bit different. We need to, be out there. We need to get out to where people are. So the staff will identify locations, clubs, and hangout spots that are frequented by the MSM community. Most of the venues are nightclubs. And as I stated before, COVID made things a little bit different. So I came onto this project last year, so I wasn't able to actually view like what a regular cycle would look like. Like I didn't get to go out, to the spots and things like that, but we still had a successful cycle. And so when we go out to those sites, we build the rapport with the business owners and establish trust so that we're able to conduct the surveys and the HIV testing right in those venues. We can do everything we need to do right there. We can do it securely and privately. And then again, our sample size is 500 for all of the cycles. Data collection. All 3 of the cycles, we're gonna collect data. And so we have trained staff that screen potential participants for eligibility. And those are, the eligibility questions are based on questions developed by BDH, CDC, and community partners. So we use a standardized anonymous questionnaire to collect the data. Everybody gets the same questionnaire asked in the same way every single solitary time. There cannot be any additions, there cannot be any subtractions in order to make this fair. So the interview takes about 40 minutes to complete, and it includes questions concerning HIV-related risk behaviors. We do offer HIV testing, and participants receive HIV prevention education. All participants are compensated for their time, no matter what cycle it is. Participation is strictly voluntary. Those taking part in the survey are given a consent form. All the risks, benefits, and confidentiality rules are discussed prior to beginning the survey. So we read everything to the participant. If they wish to stop the study at any given time for whatever their reason is, we will stop the survey with them and they will not be penalized at all. So data collection starts around June and it ends through November of each cycle. All right, so let's take a look at what that, some of that data looks like when we start collecting. So this data is from 2018, our PWID 2018 cycle. Again, I was not there for this cycle, but we do have some data. This is not all the data, but it is some of the data, so you can get a kind of an idea of what it actually looks like. And so for that PWID sample in 2018, this is the basic criteria. Remember before I spoke about seeds, we seek out seeds so that we can actually start the study. And our seed selection is important because we want to be able, we want to have strong seeds in order to grow the study. So we're gonna present the seeds with coupons, and they're gonna, again, recruit their peers in order for us to grow the study. So the criteria to be a seed is, has not previously participated in current cycle, lives in the MSA, Metropolitan Statistical Area, 18 years of age or older, has injected drugs in the past 12 months, able to complete the interview in English or Spanish, and is male or female, not transgender. There are other sites that do transgender studies. We have not been able to get those yet, but there's a separate study for that, and that's why they're not included in this particular study. Otherwise, if you're not a seed, in order to be eligible, you had to have been presented with a coupon. So a seed would have given a person a coupon. Again, has not participated in the current cycle, lives in the MSA, 18 years of age or older, has injected drugs in the past 12 months, able to complete the interview in English or Spanish, or is male or not female. So for 2018, they had 751 people were screened. 542 of them were eligible and actually completed the survey.
It's not going to the next screen.
It's not moving you on.
There we go.
Okay, here we go. So of course, when any data is collected, there's always going to be some demographic data that is going to be needed. So for that 2018 study, we had 67% male, 33% female, and then you'll see the 0.2% transgender. These are going to vary. Values may not equal 100 due to the rounding, but the 2% that you see would have been screened, but they would have been in that number of people who were ineligible, since that is a category that you have to be male or female for that to be eligible to do the study. We had 68% of the participants were Black, 24% white, 3% Hispanic, and 5% identified as other. More demographic characteristics. So we also look at age. 18 to 29 years of age, 7% of our people were 18 to 29 years of age. 30 to 39 years, 15%. 40 to 49 years, 21%. 50 to 59 years, 31%. And 60 plus years was 26%. So it looks like for that particular study, the majority of our participants were 50 and above, or 40 and above, 40, 50-ish and above. Educational level, less than high school, 31%, high school or GED, 46%, some college, 21%, and college degree or more, 2%. So the college degree or more could include those who have masters or have more than one degree. And again, values may not equal due to rounding. All right, so we do know that within our PWID community, there are a lot of people who are homeless and have been or recently incarcerated. So we do take a look at that as well. And this graph here shows that 48% of our people said yes, they had been homeless within the past 12 months. 52% of them said no. So we're looking at like almost half of the study participants stated that they had been homeless within the past 12 months. Incarcerated in the past 12 months, we have 27% that said yes, and then 73% that said no. So homeless in the past 12 months does include anyone living on the street, in a shelter, in a single room occupancy hotel, or in a car. For the incarcerated in the past 12 months, it includes participants who reported ever being incarcerated, being held in a detention center, jail, or prison for more than 24 hours. Substance use. So we have 76% of people had an alcoholic drink within the past 30 days, while 24% did not. If you look at our binge drinking category, it was 50 and 50. 50% said they binge drank in the past 30 days and 50% said they had not. Non-injection drug use the past 12 months, 80% said they had not injected, while 20% said they did inject. So for the drinking, it includes participants that reported drinking in the past 30 days, and then the binge drinking is defined as 4 or more drinks for females and 5 or more drinks for males in one sitting. All right, so let's look at some more substance use data. So injection drug use in the past 12 months. More than once a day, 76% of the participants said they had injected more than once a day. Once a day, 9%, more than once a week, 8%, and then once a week or less, 7%. For needles, I'm sorry, Robin. It skipped to the next one. There we go. All right, needle sharing, the past 12 months. So people who used a needle after someone else, 51% said rarely, 38% said about a half of the time, 9% said most of the time, and 3% said always. Participants who gave a used needle to someone else, 47% said rarely, 36% said about half of the time, 13% said most of the time, and 4% said always. So because we are looking at different behaviors, of course, sexual behavior is going to be one of those things that we look at in all 3 of the cycles. So for this graph, the median number of sexual partners is 2. So the participants who were female that stated that they had condomless sex was 83%. I'm sorry, males were 83%, females were 55%. Participants who exchanged sex for things that they needed, 28% was males, 49% female. Participants whose partner whose HIV status is positive or unknown, 61% females and 57% males. Participants who had a partner who injected drugs, 61% for females and 37% for males. HIV testing and STI testing. Those who stated they had an HIV test in their lifetime was 88%, 12% said they had not. HIV tests in the past 12 months, 39% yes, 61% no. And then STI testing in the past 12 months, 78% said yes. And I'm sorry, 23% said yes and 78% said no. The most common locations that people went to obtain testing was inpatient hospital. That was 22%. So that would be someone who was admitted and more than likely probably had to get testing. Public health clinic or community health center, that was 16%. Private doctor's office, 14%. Correctional facility or jail, prison, 13%. And drug treatment program was 11%. This data includes participants that reported ever receiving an HIV test. So remember, there's a certain number of participants, but not everyone may have reported. All right, so let's look at some HIV prevention. Received free condoms in the past 12 months. 50% said yes and 50% said no. Participants who had an HIV prevention discussion in the past 12 months, and we typically ask whether that discussion was with a doctor, whether it was with a healthcare worker, whether it was with a counselor. And there may be some other options there. 28% said yes, while 72% said no. Participants who had heard of PrEP before doing the actual survey with us, 36% said yes and 64% said no. Participants who discussed taking PrEP with a healthcare provider in the past 12 months, 10% said yes, but 90% said no. Participants that had taken PrEP in the past 12 months, 98% said no and 2% said yes, that they had taken PrEP in the past 12 months. And so this data includes participants that had never tested positive for HIV. Antiretroviral therapy use. So out of the 476 people that tested for HIV, 8 of them tested positive. 8 of them were actually seeing a provider. So that was 100% of the people who tested positive that were actually seeing a provider. And then out of that 8, 7 of them were actually taking ARVs. So that was a pretty good number. And I think there's one more. Okay, and then viral suppression. This data here is based on those 8 people. So you see the number says N equals 8. So out of those 8 people, 88% of them were undetectable. And then 13% were detectable, but less than 5,000 viral copies. That 13%, I'm sure, is because of rounding, because if we saw on the last slide, it was 12%, 7 out of 8. And these values are from also self-reported positives. And so that was a little bit of the data that we collect. There is more. And I can, if anyone is interested, I can certainly let you all know where to go to get that additional data after. But this project needs community support. So we basically rely on the community for this survey. Community support validates the project over all 3 of the survey populations. It also allows stakeholders and the community to provide input and expertise during the formative research process, which includes the exchange of helpful information relevant to the current population of interest, and it assists with seed selection. It's also important because we are able to disseminate the data findings to community partners. If people are working on projects or intend to have a certain program and they need data from us, we're more than happy to give them that data for whichever population they want, even if they want it for all 3. So I want to thank you guys for your time and attention. If there are any questions, I will be more than happy to answer them at this time. If there are any questions that I'm unable to answer, I will certainly do my best to get the answers to you as soon as I can after the conference.
Thank
Hey,
you
Jamel,
so
I
much.
had, sorry, Robin, I had like 2 questions, Jamel.
Sure.
So the first question I had was, I know you mentioned like compensation and coupons. Were they for participants, were they in the form of gift cards, or I'm curious to know what those were?
So traditionally, compensation has been cash.
Okay.
When COVID kind of happened, we switched over to the gift cards, but people prefer cash.
Okay. I mean, that's understandable.
Yeah, it's understandable. Traditionally, we have used cash, but most recently it has been gift cards.
Okay.
And it may be a Walmart gift card or American Express gift card.
Okay. And then my second question was, for the definition of homelessness, do you think that the addition of maybe if a person is just sleeping on someone's couch, if that could be added to the definition of homelessness, because some people identify that as homelessness as well if they're just couch surfing.
That is actually a good point. That is something that, this is why we have these conversations. That is something that I can certainly ask our project officer, because we have a project officer at the CDC that we meet with to determine, to get information during the formative research process and to get input from the community. So that is something that that we can certainly ask. I know a lot of times if people can provide a zip code or an address, they're not considered homeless, but like you said, they may provide the address of where they're sleeping on the couch, but they're really, they really are homeless. I don't think that that is an actual, I don't think it's broken down into certain categories, but that is something that I can certainly take back and ask about. That's a good point. Thank you.
Yeah, I was just wondering about that because I used to work at with a homeless shelter, and a lot of the individuals that would come in were living on people's couches. So I just wanted to know if that would be added. So thanks. I appreciate
I
it.
can certainly ask that. The survey is unique in that we can't really persuade people one way or the other. Like when we ask them a question, they have to give us the answer. Like we can't coax them into an answer. And so like if there's a question and the person is not necessarily, they're like, I'm not really sure. And so we read the question to them again and we say, hey, whatever this question means to you, because we want their honest input. We can't put any of our input in, but that is a good point. I can bring that back to our RPO at CDC.
Okay.
Thank you.
Those are the only questions that I had.
I have a question, Jamel. I know you mentioned, I know this is a survey basically just asking certain questions, but what if there is someone who is in need of a resource? Do you provide any referral source for individuals during this time, during the survey?
We don't provide the resources during the survey. Once the person is done with the survey and they're done with their HIV testing, then we will provide them with resources. We typically have a list, depending on the service that they need. We'll have a list of services that we can refer them to. If it is someone who tests positive for us right then and there in that moment, we do have a process that we use. We get on the phone right then and there, and we turn that person over to the agency. We do use LGBT Life a lot. So we will find a counselor that person can talk to. What we typically do is we'll call over, hey, we have someone who needs some services. We let them speak on the phone. We leave the room because our survey is anonymous. So we're not taking any names, addresses, telephone numbers from these people, emails. And so in order to keep that anonymous, we leave the room and let them speak with the other person on the phone.
Okay, great. And I have one more question. I know that COVID played a very vital role in a lot of services and how we conduct these different services to the community. And I know you mentioned that you came on during COVID. So have you heard of, in 2018, when you conducted the persons injecting drugs survey, did you hear about some of the challenges that COVID had faced? And if so, what were some of those challenges?
So I came on the second MSM cycle. I can kind of speak to the COVID challenges that we experienced in the last cycle. And that is because a lot of the project areas had struggles the last cycle. We decided to do on-site remote, meaning that people could still come into an actual location and speak to us. But what we had set up was the interviewer in one space and then the participant in another space. And they were able to interview and speak to each other via a tablet, although they were in two separate rooms. And so that posed a huge challenge for us for the MSM cycle, because remember the MSM cycle, we're usually out. We're out there with the people. Like we're building trust and we're building rapport for them to see us. Traditionally, the PWIT cycles have been done via people coming to a site. So I don't know that if COVID will necessarily affect this population for this particular cycle, because they are used to coming to a site already for it. Now, they may not be used to the tablets because they're typically sitting in front of someone, and now we're going to have them in a separate room with the tablet. So that may pose a little bit of a challenge for some people. But the way the survey is set up, it's set up so that it's easy for the participants. So they don't have to hit buttons and anything like that. We ask them the questions and we're the ones doing the input. So there's not anything they have to hit or look out for. They have headphones on and we talk to them. They talk that we can see them. And the interviewers are typically interactive with them. You know, hey, are you doing okay in there? You know, because it's about a 40-minute survey. So we want to make sure people are doing okay during the survey.
Thank you, thank you. Is there any other questions? I'm going to go and look in the chat room and see if there are any other questions. Okay. Okay, I don't see any other questions, so I thank you so much.
Thank you all for having me.
sharing. Okay, back to you, Aisha.
Thank you, Jamel, for giving such an enlightening conversation. You definitely opened my eyes to some behavioral statistics in terms of people who inject drugs in Virginia, because I'm not from here. So I definitely learned a lot from you. Next, we will have Bruce Taylor from the Virginia Department of Health and Keisha Tolliver of Richmond City Health Department to talk to us about debunking stigma with harm reduction and harm reduction conversations with patients. If Keisha and Bruce would introduce yourselves, I would greatly appreciate it.
Hi, thank you. My name is Keisha Tolliver. I am with the Richmond Henrico Health Districts. I go to different communities throughout Richmond and Henrico and educate people on Narcan and just providing different types of harm reduction tools that may be useful to the communities that I go to. And I really enjoy this type of work and being out in the community.
Hi, I'm Bruce Taylor. I'm the Drug User Health Coordinator of the Virginia Department of Health. I oversee drug user health and harm reduction efforts across the state. My job is to basically monitor the syringe services that we have going currently and help bring on new providers. So that's me. Keisha, do you want to go first? Do you want me to go first?
You can go first, please.
Coward. Let me find my stuff here. Okay, can you see this?
Yes.
Yes.
All right. All righty. Whoops. So the first slide was just my introduction slide. Overdose deaths, HIV and hepatitis. That's what we're talking about when we're talking about harm reduction from the standpoint of the Virginia Department of Health. In Virginia, new infections, HIV infections among people who share needles is on the rise. Hepatitis C rates continue to rise across the state. We're currently experiencing a hepatitis A epidemic. Hepatitis B is on the rise in certain areas of the state, particularly the Southwest. Overdose deaths have doubled since 2015 in the state, and they surpass automobile accidents and guns as methods of death in the state. And much of this is due to drug use or related to drug use. And what these statistics do not include alcohol. So here's kind of the scope of the problem when it comes to overdose deaths in Virginia. You can see from 2017 to 2020, 4 years, the number of deaths have gone up almost 1,000. In 2021, the final numbers aren't in yet, but we are pretty sure that they did increase over 1,000 since 2017. And to look at it regionally, from that area, it's kind of busy slide, but the top 3 lines, the first one is Virginia Beach at the top there, and then Norfolk, and then Newport News, and then Portsmouth, and then Hampton, and lastly Suffolk City. As 2020 came closer, you'll see the dramatic rise in the number of overdose deaths in your area as well. So what is harm reduction? Harm reduction is basically taking a behavior that can cause negative consequences and making it safer. There are a lot of examples of harm reduction. Using a seatbelt in a car is harm reduction for speeding, and for anti-lock brakes are harm reduction for speeding. Filters on cigarettes are harm reduction. A lot of things, low-fat food is harm reduction. A lot of things that we practice on a daily basis are potentially dangerous to us. And so how do you look at that and reduce the harm to people's health, and to do it in a way that you're not bringing on a burden to them? So it's kind of meeting the people where they are and say, so this is what you're doing now. Let's talk about how we can do that safer. And then you can tell me if any of these ways, if you agree with any of these ways, if that sounds like something that you would be willing to do. So it's meeting people where they're at, and not, forcing them to do something. It's just giving them different options that they have in their life. Our goal at the health department is to prevent disease and other adverse consequences for drug use for people who are unwilling or unable, or just not willing to stop currently. Harm reduction is not new. It's just fairly new in Virginia. It started in England, came over to New York City during the HIV crisis, and it is spread throughout the world. Needle exchange services is just one component of harm reduction. There are many components, which I'll talk about in a few minutes. And the goal is to improve the health and the well-being of individuals, families, and the community. So what harm reduction can do: it can prevent HIV, hepatitis B, hepatitis C. It can reduce the incidence of abscesses on the skin and endocarditis, which is an infection of the heart, by giving people alcohol pads to clean before and after they inject. It can reduce fatal overdoses by providing naloxone, or Narcan as it's called. It can increase entry into drug treatment, and does. It facilitates referrals to housing, mental health, health insurance, and other social services. We provide testing and treatment and referral for hepatitis B, C, and STIs and HIV. It helps reduce needle stick injuries to first responders and in the community, and it removes needles from circulation or inappropriate disposal. What harm reduction does not do: it does not increase or create new injectors. Most studies that have been done show that it actually decreases the number of people who are using by facilitating entry into a rehabilitation or a treatment program. You're 5 times more likely to enter treatment if you're in a harm reduction program than if you're not. It does not increase crime. It actually helps bring down crime. If you have less people using drugs, there's less potential for crime in that area. It increases, it should say decreases discarded needles in public places. So it does not increase, that's a myth. And and a matter of fact, most harm reduction sites that we have in Virginia go out in the community and actually collect syringes as well. So not only does it provide a place for people to bring syringes to, but they actually go out, and if they hear in the community that there's a park that has a lot of syringes, they'll go out and collect them. And it does not give permission for people to use illegal drugs. It basically provides a safety net for people who are using, and just allows them to do what they want to do, no judgment attached, but trying to give them a safer way of doing what they're doing. So a lot of the stigma that comes from drug use has to do with, there are two sides of what we look at as far as, drug use. From one side, it's a disease, or it's a moral. On the other side, it's a moral failing. Abolition of alcohol way back in the early part of the 20th century created a lot of the stigma that you were not a Christian person if you drank, you were a bad person if you were female and you drank, you were a loose woman, blah 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 blah. So we stigmatized alcohol to keep it from becoming to get rid of it, basically. And then it came back, but the stigma didn't go away, and that then jumped over to other drugs as well. In the early 20th century, there was also a lot of heroin use in the country that got stigmatized as well. And heroin was actually the first illegal drug that was made illegal by law in the country, followed closely after, but not too closely, by cocaine. There's a difference between use, misuse, and abuse. People use drugs recreationally all the time, and those are not necessarily the people that are being stigmatized. It's the people that are using drugs because they've become dependent on them. That is one of the reasons that the stigma exists. A lot of times people go cold turkey on a drug, so we don't know exactly how many people have stopped using. We know how many people have gone to treatment. We don't know how many people have stopped using because they do it on their own. And studies show that most drugs other than opioids, most of the people who use them don't go to treatment, they stop by themselves. Dependency is basically what we used to say addiction. Dependency is a more accurate word. It's because your body becomes dependent on the chemicals that the drug supplies to your brain. So the drug has chemicals in it that help elevate things like serotonin, which regulates your mood, and dopamine, which also is a mood regulator, but gives you the ability to feel happy. So when the drug contains chemicals that stimulate those things, it's no need for the brain to make them. So the brain stops making them, and when you don't have access then to the drug, your brain is looking for this chemical, which it's not producing currently because it didn't have to for a while. So that's what we call withdrawal. It causes people to become very irritable. It causes people to sweat, all kinds of physiological changes in the body during withdrawal. And it can also cause, in some instances, death because the chemical is necessary for the functioning of the brain to send signals for things like heartbeat and respiration, etc. So, it's important to realize that after a while, after not using, your brain starts producing those chemicals again. But for a while, your brain is dependent on the drug. So, and then there's a difference between the physiological dependency and then the psychological dependency, which would be more accurately called addiction, which is, it's not necessarily, your body doesn't necessarily need it, but you need it. You need it to cope with life. You needed to get through the day. You needed to face this person to get to your job, to stay awake at night, all of those things. So, you know, there's that aspect. And that's pretty much the harder aspect of the two to withdraw from. You know, people who stop using cigarettes do not need any type of nicotine after about 2 weeks. It's the psychological part of, what do I do with my hands? I'm nervous. What do I do? How do I, you know, get up in the morning and drink coffee without doing this? That routine. That's the psychological aspect which people keep going back to, which makes it hard to quit. And then there's prejudice. The war on drugs was basically a war on people of color. It would say, let's look at people who are using drugs and see, you know, who our statistics show are using cocaine, and that's people of color. So let's make a war on drugs. So basically we can arrest a lot of people of color that, you know, we don't want on the streets. You know, people who could be a member of this group or that group or whatever, we now have a reason to arrest them. And that continues, you know, today. There's still that racial element to drug arrest. So there's that stigma that is then tied into prejudice and racial discrimination that continues to linger. One of the things that we can do to help destigmatize people is the language we use. You know, we don't call a person a drug addict, call them a person with a substance use disorder. Something I'm guilty of a lot of times is say, you know, dealing with people, rather than dealing with people, which sounds like, you know, it's an effort for me, it's working with people. You know, substance abuse, substance use disorder, you know, all the slang terms for all the people who use different types of drugs. Just say a person using heroin or meth or cocaine, getting your fix using your drug, dirty needle and clean needle. We use this all the time, and it's so bad because the needle got dirty because of the person using it. So say used needles and new needles or sterile needles, a person suffering from drug addiction, a person with a substance use disorder. We don't pretend to know what's going on in their head. Street names for drugs use the universal name so people don't get confused. Don't call people a drug offender, call them someone with a drug violation, and on and on and on and on. So, you know, basically person first language says, define the person as a person first, and then whatever behavior is a description. So a person who smokes cigarettes, a person who eats fatty food, a person who likes to race their car. Those are all person first descriptions for behaviors that can potentially cause you issues. So how does harm reduction work in the state? These are outcomes from our harm reduction sites that we currently have, and I will discuss them more when we talk about resources at the end. In 2021, we saw 2,563 clients, and you will see that I'm sorry, that's how many were enrolled total in the program in 2021, between 2021 and between January 2021 and December of 2021. So you'll see this is a gradual decline of enrollment. We started back in 2018 in mid-year. Wasn't a whole lot of enrollment towards the end until the end of that year, and then it started to climb. And then you'll see the great jump in 2021 up to 2022. And 2022, of course, isn't over yet. So we expect that number not to dip, but continue in an upward trend. In 2020, enrollment in our services doubled over what it did, actually tripled over what it did in the past year. Since we've been operational, we've had about 29,000 visits by those 5,000 clients, and those are the dates that those numbers are taken from. 93% or 99.3% of those individuals received harm reduction counseling while they were there. 127,000 received condoms. Almost 4,000 were given naloxone. 2,500 overdoses were reversed by that naloxone on 1,511 clients. So our program saved 1,511 people just in delivering naloxone. This is the linkages that the programs have done since the beginning. They've linked a lot of people to naloxone. They've linked 627 people to substance use and mental health treatment, HIV testing, family planning, social services, testing for hepatitis, vaccines, medical care, insurance enrollment, HIV linkage, transportation, fentanyl test strips, which we just recently started. That's why that number is so low. And in PrEP, in PEP, and PrEP linkages. So it's not just needles. It's a lot of working with people with what they need and getting the services that will help them meet those needs. And that's the first part of mine. So I will then turn it over to Keisha.
Thank you, Bruce. I appreciate that. So as Bruce was saying, and I apologize, I do not have a PowerPoint. As Bruce was saying, the goals of harm reduction is basically to decrease the detrimental effects of substance use, help people get the care that they need, and then to help promote social inclusion for the people who that use substances. Important features of harm reduction are things like focusing on specific risk and the associated harms that follow it, utilizing evidence-based, cost-effective policies, which I know here in Richmond, we are working, really hard on, getting some better policies, established. Treating people who use substances with compassion and dignity. And that's something that I really speak about a lot when I'm out in the community, because usually when people see me out there with Narcan and I offer it to them, I don't do drugs. No, don't be around people that do that stuff. No, don't look over here. And the more I talk to them and I let them know, hey, they're just like everybody else. Some people, they get Narcan because they've had major surgeries and they've been given opioids that they're kind of afraid to be on. I know people that are getting Narcan just to be on the safe side. Some people know that they have family members that are allergic, or, and just in case something was to happen, because there are opioids that, some people don't even know, that they are opioids. And then, when we get to street drugs, there are opioids that are being put in the drugs without people's knowledge or permission. So it's not just about street drugs or, people feeling like, hey, that someone's pointing the finger at them. But, and then also contesting policies that harm people and include the criminalization of drug use. So myself personally, I am usually out in the community. I go to food pantries. I go to churches that are passing out hot foods. And the first thing I do is I build those connections by bringing more than just Narcan. When I come out, I bring first aid kits, which are, these are going to be some list of harm reduction products that I send out. First aid kits, triple antibiotic creams. I make sure that I have antiseptic wipes. Of course, I bring condoms. I make sure that I have toothbrushes, sanitary napkins, all different types of things that most people won't usually bring to a community event. Usually when people see me out there, and sometimes I have a big table, sometimes I have a rolling bag, but I make sure that they see, hey, that's that Narcan girl. What you got for us today? In the winter, I make sure I have socks. I try to talk to different churches and places to try to get beanies or those hand warmers, because those are a little harder to get through funding. But when they see me, they know that I'm coming with things, and not just things, that are associated with thinking that, hey, you must be a drug user if you're living on the streets, or you must be a drug user if you live in this project. So when they see me, they know that I'm coming with things. I'm there to give conversation, and I'm somebody that they're used to seeing. They usually talk a lot about what's been happening in their neighborhoods. When I'm in Churchill at those events, they let me know, hey, we had to use some Narcan, but they're okay. They're upset with me. I get to hear all of the stories. Some people, I'll see them the previous week and they're like, oh, you're doing a good job. But then I'll see them the next week, hey, well, I'll take some Vaseline. And the next week, hey, I knew this girl who overdosed. I think I need to go ahead and get some Narcan this week. And usually that's something that happens. A person will see me so much, and then if it does happen in their family, they come back and they tell me the story, and they usually feel so guilty. And that's when I let them know, hey, you did the best that you could, and now you're here. Let's not, try to hold that guilt inside. Now you're going to be armed now. I've had people come to me because their mothers are in the early onset stages of dementia, and they had a hip replacement and they were given morphine. And the lady was like, hey, my mom doesn't know what year she's in. Why would they give her morphine? And, when she was told, hey, go to the pharmacy and, just get some Narcan, it was way more than she could afford on her income. So at the health department, we're there with the Narcan. So, I really enjoy the work that I do. And I make sure that when I come across people who feel like, oh no, not Narcan, I let them know that it can happen to anybody. It could happen to you. And usually if you have the Narcan, you're there to help someone else. You're there to help save a life, and not necessarily say or admit that you're doing anything, because no one's accusing you. We just know that nobody has to die from opioid usage or overdoses. One of the things that I have started doing with the jails, because I do go into Richmond City Jail and I teach them about harm reduction, I educate them on Narcan, and they just started allowing us to give them the fentanyl test strips. Probably can't see that because my black background is all blurry, but I am giving out the fentanyl test strips. I've had the young men in the jail, while I'm talking about the Narcan, they're like, oh. But then when I started talking about the Narcan, the fentanyl test strips, oh, okay. And everyone wants to know, well, what's going on, because everyone has had a friend who has overdosed from fentanyl and marijuana, who they only were doing this one thing the one time. And and so when I have those conversations with them, and they start hearing about the fentanyl test strips and how they can actually test the substances, when I see them in person to give them the items, because I give them the education, and then I go to the jail and actually give them the Narcan and the fentanyl test strips, I've had them all, so many of them, hey, you're really doing a good job. Thank you for talking to us. Do they pay you for this? And they really have a lot of good questions. I've even had someone who, once he did come out, once he was released, he called me the first thing. I'm serious. I want to help. And he wants to actually volunteer in the community to let other people know, hey, we don't have to be afraid to talk about this. And so I really love the work that I do. And everyone's like, hey, thank you for the work that you do. But to me, I thank the people who are strong enough to come get the Narcan, or to let people know, hey, there's somebody who's going to be at Bethel Church, giving this out. And, to me, that's what's more important, that people are open to being more kind to other people and helping others. So I know I kind of went overboard, but thank you.
That was perfectly fine, Keisha. Thank you, Bruce and Keisha, just for giving us, such valuable information. It was a lot. I know that Keisha, I want to thank you for, really stepping out into the community and giving those resources because, I think that's valid. And, just for letting us know the conversations that you had with some of these people, because we don't always get to know what's going on, on the street or in homeless shelters, food banks, whatever. We don't really know what's going on. So thank you for giving that information. And thank you, Bruce, for giving us some statistics about what's going on in terms of harm reduction. I had a question, if no one else had a question. This is for Bruce. Bruce, do you think that, because I know on the first slide, I think you had the number of cases and it looks like the arrow was kind of going up. Do you think due to the pandemic, that's the reason why there'll be like a rise in opioid cases in certain places?
I think the pandemic had a lot to do with it because it basically made us all like cloistered in our homes, and we didn't socialize, and so people were using alone a lot, and that's one of the reasons that people overdose and die the most, is because if they do overdose, there's no one there to revive them. So using alone is is not ever a good thing to do. And then the other things like the angst that it caused everybody, we can't do this, we can't do that. And, just basically, the different, I guess, ugliness the pandemic caused in society as well, gave a lot of people, the feeling like, I need this more than ever now. So, it's a coping device, and it's a very effective coping device. So people tend to use it more when they're stressed out.
And in addition to that, Bruce, everyone was getting some type of financial increase. So, you were getting $1,400 here, and, this person would pay your rent. So if you didn't have to pay your rent, you had extra money. So, that made it a big deal too with the pandemic.
I do have a statement. One, I just want to say thank you both, Bruce and Keisha, for just doing the wonderful work that you're doing in the community. Keisha, a lot of times when, I've been in this field for almost 14 years, and to have that trust in the community is very important. And just based off of the conversation or the information that you just provided, that the community trusts you big time. And so I guess my question, you mentioned that sometimes people may be reluctant to you in the beginning. Like how like if you were able to give like an estimated time frame of when people start to come over and try to fill you out to see if your intentions are good, like what is that time frame?
It's usually and again, another thing that I usually have are the COVID tests to be able to check to see if you have COVID. So usually that's the first thing that bring people over, because they see, hey, first of all, is she selling it? And if she's not selling it, is she giving it? And can I get it? So when they're there and they see the other things and they say that, I'm like, well, that I understand what you're saying. And then I'll tell them the story as to why I do what I do. And if you have a moment, I don't mind sharing. My brother, he was working 2 jobs. He was dating a young lady who her drug of choice was heroin, and his feet was swollen. He was super tired, and he asked her, "Can you go get me a Percocet?" So she went out, she went to her drug dealer, she got the Percocet, she got a little something for herself, came back, gave it to him. She realized that he had fell asleep, but like an hour later, he fell asleep, and she went to wake him up to tell him to go lay down in the room because he was, snoring really loud. And when she touched him, that's when she realized, okay, something isn't right. She couldn't get him to wake up. She realized he couldn't breathe, and he went from snoring to trying to catch his breath. or that the just he was losing breath. As she realized, okay, I think he's overdosing, the first person she called was me. She's like, hey, your brother's overdosing. And at that time, I didn't know anything about Narcan. It was 2016. I was just raising my children. I didn't know anything about anything. And so the first thing I'm telling her is like, call the ambulance. And so when she called me back, which was almost an hour later, she's like, well, the ambulance, they just came and they said that he's gone. And so we were all shocked as to, well, what was going on? Later, of course, we found out that the Percocet that he had was laced with fentanyl. We also found out that the reason it took so long for her to call me back is because she sat there and had to make the choice of, do I call the ambulance and they see that I have drugs in this house, I have custody of my grandbaby, they're going to lock me up and they're going to take the baby. So the first thing that she wanted to do was to clean up. And so in the process of her cleaning up, by the time she called, he had passed by the time that he got there. So once I tell somebody that story and I let them know that when she called me, if I had have had Narcan or if I knew about Narcan, I already knew they were doing, they were doing different things. So I would have made sure that they had Narcan. I would have been able to go to the house and give them the Narcan, even if it wouldn't have been enough time. But, you would do whatever you can as if you knew about the tools. And so when I talk to people and I tell them that story, I've had a lot of people, and by the end of that story, go ahead, give it to me just in case. I may not use it. Like, I hope you don't have to use it, but I hope you never have to have it and you don't have it. So for a majority of people, by the time I finish that story, they want the Narcan, they want the training, they want my phone number to make sure that, if anything happens or they have to use it, they can get more. So it doesn't usually take a long time, but by the end of that story, I usually, for the most part, wind up talking people into getting the Narcan.
I think that's very good, especially for like the storytelling, especially since this is something that happened that's personal, to you, lost your brother due to stuff like that, which is why even like with stuff like harm reduction and our past conversations we were talking about, there's one Facebook post where everybody was like, oh, they're trying to give crack pipes for equality or some wild stuff on Facebook and Instagram. And it does really, storytelling is one of the most compelling ways to kind of like help someone like see how you can you're thinking about this way, but you try to think about it this way, in a more humane way. I think of it as prevention, and through this story, like this is a way to connect. Which storytelling in general just is an awesome way to connect. So I think if we definitely do that more, especially with things that happen, I think we can definitely get more people on like the side to do things. So thank you so much for sharing that, Keisha.
Yes, thank you for just being transparent and sharing. Sometimes, things like that it's sometimes difficult, but and like Jason mentioned, like sharing stories is how people will go ahead and begin that trust and say, okay, well, maybe I could use this. The Virginia Harm Reduction Coalition mentioned that the long-term goal is to make sure that a box of Narcan is in every house, in every car, and a first aid kit, which is definitely much needed. So put, fun fact, it is very difficult to overdose while smoking a substance. I'm just saying.
Just in case people have feelings about the $35 million crack pipes. You just share that fun fact with them.
Yeah, I saw that post on like Prep for All's page on Instagram, and then in the comments it was just social media chaos, turmoil, and misunderstandings, and people that don't know what harm reduction is. And so that honestly, through that, as in my conversation with Keisha is what inspired this event. Me wanted to definitely make this event. So thank you so much for everybody to jump on and share knowledge and everything. Definitely get into the next start to get into the next portion of it. It is right now 7:39.
I do have
Um
one more, I'm sorry, I do have
mhm.
one more question for
Oh
Keisha.
yes.
Approximately, like, about how much Narcan do you give out in a week?
So it really, really depends on what's going on that week. Last week I gave out maybe 36 boxes of Narcan. But for next week, I have pulled out at least 96 because I have 2 events where I know that there are going to be at least 30 people at those events to get educated on Narcan. So it really depends on the week and what's going on. I also give Narcan out to different organizations. For example, Rams of Recovery with VCU. I make sure that I give them at least 24 boxes every 2 weeks. So it really depends on what's going on that week and who's coming to me who needs the Narcan.
And then I guess my next question, where's this best place to put your Narcan in your house? And then also, does anyone have any links for people to, if they may want to order, if there's any links to order like Narcan online or in their area, like, or is that available?
There's
Uh,
no there's no link to order Narcan online. It's a prescription medication. You need a prescription for it. However, with the standing order from the health commissioner, it's made available to Virginians in pharmacies without, an actual paper prescription. You can get it at most health departments. You can get it at most community services boards. You can certainly get it at the CHR, the Comprehensive Harm Reduction sites. You can get Virginia Harm Reduction Coalition gives out tons of it. How many do you give out a week, Danny?
I couldn't tell you a week, but I can tell you that in the last 4 months, we have given out in just our Roanoke location 1,960 total boxes of Narcan to about 720 different people. And then our Virginia Beach is usually about half of that.
And so everyone knows a box has 2 doses of Narcan in it.
Yep.
Wow, that's much needed, definitely. Thank you. But I do have one question someone asked. Are school systems receptive to education of Narcan?
There was a law passed that school nurses and teachers can have naloxone just recently. I don't know if they do education on Narcan or naloxone in their drug unit, if they do have it in their health class. I would hope that they do. Danny, do you know?
Not like as far as like widespread, no. I will say though that since that law has been passed, I don't know if Lisa's had the same experience, there has been increased interest, I think, from high schools. I think there's this perception, right, that like this is too advanced for teenagers, but the overdose median for people under the age of 21 is 15 years old. So, and we had a high school down here in Southwest that had 5 overdoses in 1 week at the high school. So I think those two, that statistic and that experience is definitely kind of changing that perception. And I have heard just in the last month, a little bit more interest from education people saying, hey, could you actually come talk to people about this?
Yep, us too, Danny.
Yeah, I have not had any schools reach out to me, but I have had a lot of parents reach out to me to educate their children. I'm actually meeting a woman on Saturday to educate her 15-year-old and her 19-year-old that's in college. So I have a lot of parents wanting their children to be educated.
And not to take over, but to piggyback off what Danny says, we have given out, I think my last number last month was somewhere like 700 doses. And Danny and them are out doing outreach. You guys are out 3 days, right, Danny? So we're out 2 days. So combine Danny and I's number together, and that's what we've distributed in pretty much Roanoke City, Roanoke County, the areas that we're in. So between the two of us.
And like, for those of y'all not around here, Roanoke is not a big city. So like, that's how
not.
great the need is that 2 separate programs, we have our hands full.
Yes.
And that leads us to our, our next section of harm reduction resources. And we have Danny, who is the executive director of the Virginia Harm Reduction Coalition. And we have Lisa, the comprehensive harm reduction program coordinator, Council of Community Services. And we have Kiera, who is the outreach worker of the Virginia Harm Reduction Coalition. So I know we already got started a little bit, but thank you. That means it just flowed into, one of the questions that I do have, and is there a difference between a rural area, just like Roanoke, in how you distribute Narcan or provide services versus a city area like Richmond City? And if so, what are some of those differences?
Yes, there is absolutely a difference. What you see more in rural areas is the need to do more delivery based. So that's why Lisa and I both have a mobile unit, because the ability to get transportation to where we are is very much limited. And it's not, if you're in the hills and hollers out here in Southwest Virginia, you don't there's not a central location. Like they're not going to let us set up at the country store gas station, that's not, because everybody sees you there, right? You can't just set up in the center of this little community because of the stigma and shame. And so we do a lot in more rural areas. You do a lot more mobile outreach, where in some of the bigger cities, you can have like a brick and mortar store, brick and mortar organization that, Baltimore and DC, and, it's right down there in the thick of it where everything is, and they have their own building. Whereas I think we have to be a little bit more strategic because of the not in my backyard kind of mentality. So you really have to be discreet and temporary in your work.
Absolutely. I would agree. With us, we have a brick and mortar right in a space just like Danny does, but due to nobody wanting our program 3 years ago, we cannot even store syringes in our building. We can't do distribution out of our building due to our landlord not allowing that. So if, I'm sure if both of us were able to distribute out of our building, the folks that we could reach in the areas that we are would be substantial. Transportation, as Danny said, is a huge issue. We have people coming 45 minutes, an hour away. So one of the things we make sure and do is when they can make it to us, we make sure they have the supplies they need for X amount of time. If we can only give them a limited supply and they can't make it but once a month, then we're really causing harm instead of, taking that away from them. So we try to make it as easy as we can for the folks that travel a long way to see us or that just don't have a way to get there.
Along with Narcan, are you exchanging needles? Like, do you offer the syringe exchange program? And if so, how long have you been doing that?
So our program, we do syringe exchange. Like I said, we only do the syringe exchange out of our mobile unit. We've been operating for 3 years. And I will tell you the first year, probably the first 6 months to a year, I was thinking, I'm not sure I'm going to have a job. It took a long time for us to be accepted, maybe is a good word. I don't know that we still are.
Maybe tolerated.
Maybe. We did our neighborhood, our neighbors across the street from us was just terrible, the whole experience. A lot of that was done before I came on board. But in the last year and a half, there are days when I'm thinking, I don't know how we can do anymore. sometimes I stand back and think, I never thought I would see this program like this. So those are the days that I take every success I can get, every person that comes to see us, as well as Danny. You know, I take that as a success, that we're doing something right and meeting people where they are, for sure.
Yeah, and I wanted to, at one point, somebody was like, how long does it take to build that trust? When Keisha was talking about her work in Richmond, and one of the greatest facilitators of this work is recommendations from the community, right? We average about 100 new enrollments a month between our two sites. And those enrollments it's almost always our participants coming like with a friend in tow to be like, sign him up, you know, kind of thing. And so that's, and that really, I think one of the things that people aren't aware of in harm reduction work is that it is 100% relationship based. And I think Keisha did a really good job at demonstrating that. And so we have to come correct, right? If people aren't showing up to your program, that's on you. And so, you know, we have to do similarly. We've been here for about 3.5 years. We incorporated in November of 2018. And if you aren't coming correct, like, you will know, the participants will tell you, and they won't come back until you straighten up.
Right. And they definitely will. You know, it is so important, like you mentioned, you know, that personal relationship that you have with the community, that trust that you have with the community. And if you don't have that, a lot of things will start. So yes, definitely, I agree with that. So let me ask you this question. What are some of the lessons learned for you for the different agencies when you are working with harm reduction? When you talk about harm reduction, what are some of the lessons learned?
Lisa, I'm gonna let you start. So. You go first.
I will say I came into harm reduction knowing probably less than zero. Less. In the last 3 years, the knowledge that I have learned from our participants alone, I never knew of what our community was like. And the drug user community is a resilient community. They stick together. They take care of each other, sometimes way better than a quote unquote normal community does. So to me, I love seeing folks that don't know each other. They meet at the van. Hey man, we're going to go get pizza. Hey man, I've got food. I've got a bag. So they take care of each other. So to me, that has been a huge eye-opening thing that I have learned. I tell people, I knew nothing about ordering syringes. I ordered, and I'll be honest, I ordered shitty ones and I heard about it. I've never ordered them since. But I've never injected drugs. I've never lived on the street. So for me to tell someone what they need when I have zero clue what they need, I always tell people, this is your program. I'm just here to take care, and you tell me what you need. And we try really hard to do within our limits what we can. So that's been my biggest takeaway from doing this job. I can't imagine having a better job.
Yeah, I think lessons learned, I mean, totally echo everything that we said. And, you know, for people that are interested in participating in harm reduction programs or supporting them, I think one of the things that's really, really important is to make sure that you have people with lived experience in your program, right? Because then you can go to your staff member and say, which needles are the good ones? And they will sit down with you and tell you exactly what to order, right? On the computer with you, right? So I think making sure that you have members of the community on your payroll so that you can learn from them 24/7, not just over a 15-minute interaction with the van. I will also say that when working with agencies, the biggest lesson I've learned is that you just have to like plan for education. Anytime that you're partnering with somebody, we made the mistake of, we were working with some people at the local health department that were 100% on board and so supportive. And the day came and they had all their public nurses show up at this trap hotel that we work at. And the people above at the top, you know, said, yeah, we're like, it's going to be great and we're ready and we're here. And then they had like told the staff where they were going and what they were going to be doing, the population they're working with. And the staff was totally freaked out. The public health nurses were totally freaked out. So we stepped back and we did a lot of education, and I spent a lot of time talking with the entire public health unit, saying like, this is the reality. This is what, like, this is your safety. Let me tell you about my staff, you know, all this kind of stuff. We've been here for years and years doing this work at this exact location. People trust us. You are safe with us. And now when the public health nurses, we've been doing this now for 3 months in a row, and they just come jumping out of the RV and I'm so excited. And, you know, they're so happy, but it's because you have to put in that groundwork. You have to assume that anytime you're partnering with anybody, like you have to go slow and spend time educating them on what harm reduction is, on who this population is, what they need, and teach them, right? Because Lisa and I have had 3.5 years of education on how to come correct. You have to translate that 3.5 years of experience to everyone you partner with. So yeah, so that's probably the biggest lesson that I have learned is education, education, education.
What supportive services do you feel are lacking for persons experiencing substance use disorder?
Dana, you can take this one.
That's fair. Housing. I mean, like everything.
Yes.
Everything's missing. I think housing is the biggest challenge that we're facing, because we have the HAT team, the housing assistance team here in Roanoke, does really great work. But there's no apartments to send people to. So even if we get our clients into the HAT team and like get them set up with a voucher, there's no Section 8 housing here. And so I think housing is probably the biggest issue that we face. And then it's like, when you talk about supportive services, it's like, it's everything. It's, you know, a client can't get, so this one, they couldn't apply for Project 8, Section 8 housing because they didn't have a social security card. So they went to get their ID in order to get their social security card, and they can't get their social security card without their ID, and blah, 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 you know, and it goes on and on and on, right? And so and I have so many clients that I, you know, need to reinstate my license, but it costs $120, and I don't have $120 to reinstate my license. It's just little barriers everywhere. And then, so the supportive services that exist are overrun. And then a lot of times the supportive services are designed for the lowest hanging fruit. They're designed for the easier clients that are ready for recovery, that mostly have their lives together and they just need a little help. The people that are experiencing generational poverty, generational drug use. I mean, I have met several of her, I know a client that started, she did heroin for the first time when she was 8. I know another one who the first time he was 11. His cousin showed him how. So it's like, you have generational drug use. You have grandma, mom, and granddaughter all using in the same house. Like it's going to take a lot of support to overcome these barriers and challenges. And so, yeah, what's missing, I think, is just we just need more, and we need the resources to be able to, you know, our social workers go and sit with their clients through every meeting. And those meetings sometimes take like 2 and 3 hours. And that's a niche that we have the privilege of filling. We need more. We need more.
Yes, yes, yes. Yeah, I echo everything that Danny says. And, you know, mental health services, everything. We see it on a daily, weekly, hourly basis. As Danny was saying, our HAT team, you have to be there at 6:30 in the morning to get one of possibly 4 slots, then only to be told, sorry, we can't help. So yeah, it's frustrating for us. So I can't imagine being the person, how frustrating it is to try to jump through the hoops that just aren't there.
Thank you. And there's a comment, a question. Are there supportive services for families, specifically the kids?
There is one, there is one here that I think just recently got a grant that covers families and children. It's, I believe it's through Family Services. I haven't heard a whole lot about it. I think I was at a meeting. So I think that's the goal of this program, is to, if in any way you've been affected by opioid use disorder, anything like that, they're working with families and children.
Thank you. I do have another question. How has the opioid epidemic impacted the LGBTQ community?
So I can talk to this. As a member of the LGBTQ community, I'm genderqueer, I'm trans-identified, and lesbian. And, you know, the thing about substance use is that, you know, and I know I'm preaching to the choir here, this is hosted by the LGBT Life Center. Excuse my dogs, like I said, proper lesbian. So the, leave it. So the issue is that with all the stigma and lack of social support and familial support that LGBT people have, we are so much more likely to experience substance use disorder and mental health issues, right? Because of the toxic society we live in, right? And so when you say like, okay, how is it disproportionately impacted us? Well, first of all, we're more vulnerable to substance use disorder. So we're already got a tick against us. And then if we are then, you know, have the misfortune of having substance use disorder and particularly opioid use disorder, then you are faced with all of the vulnerabilities and stigma associated with having an LGBTQ identity is then piled on top of all of that substance use stigma and homelessness and insecurity. If you have a misdemeanor or a felony conviction that's related to your drug use, and you're transgender, and you're Black, like you are the last person that's going to be hired. Oh, and you have substance use disorder, or you're recovering from that, you're the last person that's going to be hired for one of 5 positions that 200 people are applying for, right? Because there's only so many employers that will hire people with past convictions and with that are in recovery or are actively using. And so we're just incredibly vulnerable. We have, off the top of my head, I can count like 5 regular trans clients, and they are incredibly vulnerable because let's say they want to pursue recovery. Well, then a lot of recovery programs are religious based, and a lot of LGBT people have religious trauma. So then they have to try and find a recovery program that isn't religious based, or at the very least is affirming of their identity. That's incredibly hard. Like, how does a trans person go to recovery when that's almost always segregated by sex? Where do they go, right? So there's just a lot of issues, which is why I think, again, it is really important to be including people from the community with that lived experience. And unfortunately, Kiara couldn't be here tonight. She was here at the beginning, but she had to go reverse an overdose, and she reversed 2 overdoses in the course of 25 minutes. She reversed one and the other one didn't make it. LGBT people are on the front lines of this. They are the ones that are saving lives every day. They're the ones that are losing loved ones every day. They are the most vulnerable. And so when we talk about harm reduction, you would be surprised at how queer, very, very queer harm reduction is, because what LGBT people know how to do is make it work for themselves. Something doesn't exist, we gonna build it. And that's, you know, very much, I think, how harm reduction works. And so it's really kind of a match made in heaven when you look at it that way.
Right. LGBTQ and people in general are just very resilient, you know, and you're absolutely right. It is so much harder. Like even you mentioned earlier, housing, you know, housing, or, you know, for a trans person to go into a shelter, that is just difficult sometimes, you know. So there's still a lot of work that we need to do. And, you know, I just appreciate everyone that's here today, because the biggest piece is advocacy. And the biggest piece is just, stepping in the trenches and just building these relationships with the community just in general to provide a service. I do have another question. So if you could encourage someone right now in this moment to seek help, and anyone can answer this question, what would you say?
So I would say, well, I'm going to flip this question on its head a little bit. For the person that's ready to seek help, we are here for you. We love you. Like, don't go through this alone. There are so many people out there that will love you and want to support you. But the way that I actually really do want to answer that question and focus on is, if you know someone that needs help, if you know someone that has substance use disorder, the best thing that you can do for them is to love on them. You really gotta love on them, because for 100 years, we have been told that the best thing you can do is let your loved one hit rock bottom. They have to lose it all in order to want it back. And everything we have learned in the last 100 years shows that's fundamentally not true. Letting someone hit rock bottom, cutting them off. We say that the opposite of addiction is not sobriety, it's connection. And the worst thing you can do is cut somebody off. We understand you have to hold boundaries, right? You can't steal my things and stay in my house and try, you have to have boundaries, but never stop loving them and expressing that love, and fighting so hard to keep connection with them, because it's the connection that's going to save their life, right? Because 100 years ago, rock bottom was pretty miserable, but now rock bottom is dead. And so with fentanyl. And so that's what I would say is if you are seeking help, like, let us love you. We love you and we're here for you. And if you want to support someone seeking help, just love on them as much as you can.
Yeah. I lost my dad when I was 3. He was an alcoholic and hit rock bottom numerous times, according to my family. Well, rock bottom, as Danny said, I couldn't have said it any better. It killed him. Rock bottom was my mom, my grandmother. So, and every loss, I don't even know who Danny lost today. It's crushing to our community. People are dying, and yeah. So we have to love everyone, no matter where they're at in their journey, whether it's beginning, middle, end. We all need to be there to take care of each other. We need to be like the drug user community. We need to be resilient. We need to take care of each other. And so we do not do a very good job at that. And my story is, I lost a participant. It was the first one I'd lost. I took it to heart. I didn't want to go out doing outreach that day, which is the best part of my job. I went out that day. It was someone in the community that everyone knew. And I was told that today they were going to be my support system. And that meant more to me than anything. I needed them that day. They didn't need anything from me. So they're amazing. They are just amazing.
Yeah. And Danny, that was like the most perfect thing to say, because that's the biggest thing that I tell people when they come to me and they say, what do I do with my sister? Should I do this? And that's the first thing I say, because with me, I did it the old school way. Be hard, be firm, tell him this, and you don't have to be around that. And you come home and we'll do this. And when he saw me, I just was always the same way. Have you stopped? Won't you come home? And it made my brother put some distance between us, because I was trying to do it the old school way, into the hardness. And when he did pass, that was like all I could think about. I didn't get to tell him that I still loved him. I didn't get to do this. I didn't get to tell him, I hope he knew that I loved him. And so the guilt of knowing that I didn't have to be hard on him. I didn't have to be stern. I could have still been the same loving sister when we grew up and still been there for him instead of being hard, which is the way that I've always been taught. I'm 45. That's how we were always taught. And so when I go out, that is exactly what I tell them. Love them, love them, love them. They don't have to be in your house, but love them. Let them know you're here for them. Find resources if they need help. Call those numbers, give them the numbers, but yeah, most certainly love.
And Danny, I'm sure you're like me. You answer the phone no matter what time it is. Because let's face it, people don't overdose between 9 and 5.
No,
it's not, our job is not a normal everyday job. It's midnight, it's a Saturday, it's a Sunday. When you have stuff going on, they have stuff going on. So you just need to be there. If you tell them you're going to be there, just be there.
I get asked a lot by people who make decisions with money and laws and this, that, and the other, why are programs so successful? And this is why they are successful. A population of people who is used to being told, go away, we don't have services for you, you're going to steal from us, this, that, and the other, to go into a center of people that love them, does more for self-esteem than anything else in the world.
And when you have folks in jail that write you letters and they say, I can't wait, and we're the first place they come when they get out of jail. They just want to come and see us. It doesn't have to be for anything other than just to see us, or we still have that connection even if they're incarcerated. I love getting letters that say, you have no idea what you did for me when I was on the street. A lot of times you were the only person or group of women, because it's 3 women. I'm a grandma, but it doesn't matter. So to get those letters and knowing that they actually felt what I want them to feel, it's not some made up crap. It's truly how I feel, and to get that back from them and knowing that's what they feel from me.
Yes, thank you. Thank you. And I guess, one, I would like to say, I'm going to show transparency, is that, growing up in New York City, my mom was addicted or dependent on substance use. And as a child, I didn't, and LGBT. So as a child, I couldn't understand why, she wasn't there at that moment. But I do now that she has over 20 years now of recovery. And when I think about her journey and the things that she has gone through, I tell her all the time, I am just so proud of you. And I think that we need to let people know, that, we understand the journey and that we're proud, and we're going to continue to support you regardless. So I think every person that is on here today, and for the unknown heroes that I know that was put in my mother's place. So for you, I say thank you, because I know there were people just like you that had helped her. So thank you. So how can, and I guess this is the last question because it's already almost about that time. But if other agencies wanted to become an agency to distribute Narcan or become a syringe exchange program, a site, how can we do that? And I guess Bruce would maybe be able to answer that question, or maybe Danny.
Yeah, sure. So to become a harm reduction program, you have to go through quite an arduous screening process. It has become more arduous now than it was previously, but the thing is, you apply through the Virginia Department of Health, and there is a committee that reviews them, and then it gets bounced around a couple of times and back to me to talk to the site about potential things that could be problematic and this, that, and the other. And so I basically work with sites to help develop them, to get them to where the commissioner will approve them. The Narcan distribution is much easier. On our website, there is a, on the comprehensive harm reduction page, you can Google BDH-CHR, and that will bring you up to the comprehensive harm reduction webpage. And there's a link on there that says Naloxone Partners Program. You click on that. If you are a legitimate business, we don't partner with individuals, but nonprofit, church, governmental agency, small business, large business, anybody who has direct contact with people who are using opioids. It's not just let's go do a community carnival event type thing and hand it out. It's people who have direct contact. And we do that because money. Narcan is expensive. It's very expensive. For us as a state, it's like $77 per kit, which contains two doses. And if you were to buy it at the pharmacy, it's like $125 or some ridiculous number like that. So unfortunately, we would love to do what Danny's goal is, to have every house with Narcan and every car with Narcan, but reality is that we don't have the money for that. So we're trying to put our money where it will do like the biggest bang for the buck. And so that's why we've chosen those people for the Narcan Partners Program. A lot of opioid treatment centers are partners. A lot of free clinics are partners. A lot of probation officers our offices are partners. And we certainly, want more. I mean, the more we can get, the better. And I'm glad you will get there. We'll get there someday, Danny. I agree.
Yes, and Jamil just mentioned that we will have Narcan available to all of the participants who want it for the cycle for the NHBS.
Yeah, we're
cycle.
supplying that to them too. Yeah.
Yeah. Mm-hmm. And LGBT Life Center, we do supply Narcan. We are in our implementation stages of that. So LGBT Life Center is one of those distribution sites as well.
I will also say, because I know you guys are kind of based in Norfolk area, I know Bruce is working really hard to stand up a comprehensive harm reduction site in Newport News. And in the meantime, that will hopefully be able to expand into Virginia Beach. And in the meantime, we have a small team in Virginia Beach as well. So you can reach out to us until we're able to stand up that comprehensive harm reduction site in Newport News.
And don't they also have a Facebook page, Danny? Virginia Beach Harm Reduction?
Yeah. So yeah, Virginia Beach, Virginia. So if you go to Virginia Harm Reduction Coalition, and I'll drop it in the chat real fast.
Okay.
Yeah. And I have a page of resources if you want me to slap it up, Robin.
Okay. Yep. That'll be great. Thank you.
Right. Yeah.
So once again, oh, you're sharing your screen, Bruce? Okay.
There you go.
Okay.
And
Awesome.
Danny, I don't have your website. If you want to put that in there, you can do, or put it in this chat. That would be great.
Okay. Wow. Thank you so much. We will definitely, this was a very rich discussion. And I appreciate once again, each and every one of you for just sharing some of the great work that you're doing in the community. And I know the community appreciates you as well. We will definitely have post these resources that are available. Excuse my dog. But thank you so much. And if you definitely have any questions, please feel free to either contact Bruce. You can contact Robin Wilson over at lgbtlifecenter.org. It will be rwilson.lgbtlifecenter.org. At lgbtlifecenter.org. It's been a long day. Okay, thank you.